I'm Dr. Ira Kirschenbaum. I am the editor of the Journal for Orthopedic Experience and Innovation, otherwise known as JOEI. We run these Wednesday night sessions, just like Wednesday night in Boston is Prince Spaghetti Night. In the rest of the world, it's Joey Open Mic Sessions. We have a great topic today talking about strategies of profitability in ASCs. I want to encourage everybody who wants to participate. Most of the time, what we like to do is we put your question in the chat. And when you get your question in the chat, I'll call on you. You open up your video and we'll make you part of the discussion. Okay. I'd like to first introduce our faculty. I'll have them introduce themselves. Arjun, why don't you start first?
Hey, everybody. Thanks so much for having me. An honor and a pleasure to be here. Arjun Saxena from Rothman Orthopedics. I'm a hip and knee replacement surgeon, and I also serve as a director of our ambulatory surgery centers at Rothman.
Great. And we also have Jason Simon from Boston.
Good evening, everyone. My name is Jay Simon. I'm a sports and shoulder surgeon at Newton Wellesley, which is part of the Mass General System. I'm the vice chair over at Newton Wellesley for orthopedics, and I'm the medical director for our orthopedic subspecialty services and our walk-in clinics. But I also am part of the triad for managing our outpatient surgery centers.
It's great. So let's start, and we'll have people type in as we go. ASCs are not a new thing, but there are new trends. There are new opportunities, and it's always a moving target in a lot of ways. Jay, why don't you start off? Talk to me a little bit about what trends you have seen in the last few years are related to ASC profitability, and include in that some of the biggest challenges you think for 2025 for profitability of ASCs.
Well, we just jumped right in, didn't we?
Yeah,
Um,
we don't mess around here on Joey.
So I'm sure that everybody on this call knows that that reimbursements have certainly not kept pace with inflation. So what we are bringing in from revenue from a rotator cuff, for instance, is far less than what we were doing 20 years ago, despite the fact that inflation is climbing at a pretty spectacular rate. The ambulatory surgery centers and the outpatient surgery centers have been growing significantly over the past few years, and I think the projected growth is still over 21% or something in that range over the next few years. And one of the reasons for that is because it's becoming more challenging to operate out of the hospital setting, and it is easier to move cases to the outpatient setting, particularly since CMS has been changing some of the guidelines. For instance, last year, total shoulder arthroplasty was approved for the outpatient setting. And there's been a push to move a lot of these cases to the outpatient setting, not only for profitability for the surgery centers, but also to take some of these cases out of the main campuses to make room for the higher margin cases that require the accessibility of the services provided by the main hospitals.
Arjun, how about you? What are the big challenges we're going to face in 2025 in
Yeah, yeah,
profitability?
very well said, Jason, and I agree. With the as far as trends, joints and spine cases moving outpatient has been huge, and that's really helped profitability. And now I think the biggest challenge is what are the obstacles to profitability? And I think the number one obstacle right now is anesthesia costs. The anesthesia costs have gone up significantly at multiple facilities, and a big part of that really is the private payers really ratcheting down the anesthesia reimbursement and just simply making it challenging for them to get reimbursed for the work they do. I think recently, I can't remember which company it was, but tried to put out a plan where they were going to stop paying for anesthesia if a case went too long.
Yeah.
An anesthesiologist has no control over that, right? But unfortunately, anesthesia has to pass that cost off to somewhere. There's also a huge anesthesiologist and CRNA shortage. So the combination of the lowering reimbursement for anesthesia and the lack of providers and remember now there were only so many ASCs. Let's say a couple thousand in the country 15 years ago. Well, now we've probably tripled that number, and they still have to serve the hospitals too. So really, there's a huge workforce shortage. So now not only are they getting paid less on the insurance side, but there's fewer of them. So, I mean, when you look at hospitals, they're giving CRNAs six-figure bonuses to sign on. So, really, the biggest challenge I think ASCs face in the next 2 to 3 years is going to be anesthesia costs.
It's amazing. It's amazing. We did a time-driven activity-based costing study at our hospital looking at wheels into incision. And we also found that anesthesia costs were a big driver during that time period. And that Charlie the Cook has talked a lot about that idea of wheels into incision
Yeah.
being being optimizable. No question about that. So we have some decreased reimbursement. We have some costs along the anesthesiologist. What kind of strategies are you trying to put in place for cost management?
There's a lot out there that you can do from an anesthesia standpoint. You can always look to see if there's other groups. You can go more CRNA heavy as opposed to MD heavy, or MD or DO heavy from an anesthesia standpoint. But the one of the big ones we looked at is our supplies. How much are our supplies costing us? And where we went first was total joint implant costs. So, at Rothman, we have the luxury of having 8 surgery centers. And, what we did was we created an RFP just like a hospital would. Now it's challenging if you're a 3-room surgery center and you might do, 200 cases a year. It's going to be hard to get your price down. But with 5 or 6 centers, even a specialty hospital or 2 specialty hospitals included, we were able to ratchet our prices down with vendors, and we were really successful because we got physician alignment. So we didn't lose any vendors. If you wanted to do Stryker, you could do Stryker. You wanted to do DePuy, you could do DePuy. But everybody came to the table, and I got to credit the vendors; they were good partners in it. But that was one place that we think we're going to see 7-figure savings over the next few years.
Excellent. Jay, your experience in cost containment or cost management across the board?
I think, Arjun, you hit the nail on the head with that. I mean, one of the biggest cost drivers are implants, particularly for orthopedic surgery. And when we're talking orthopedics with the surgery centers, the biggest cost we see are from our implants. Porter and Derek are both on the call, and one of the groups that we're all working with is with Avant-Garde was looking at the cost drivers similar to what you did with TDABC for rotator cuffs and what are the drivers. And there have been multiple studies that are showing that implant costs, anchors in particular, are one of the biggest cost drivers for rotator cuff surgery. So cost containment for us, one of the biggest things to focus on is not only the cost of the implants that we're doing, because orthopedic surgeons notoriously will lowball their guess on a price for the high ticket items and overestimate the cost of the low ticket items. So a lot of us don't know what we're spending on implants. So that's very important to, as Arjun said, to get alignment with the groups and the physicians to make sure that they're on board. There's a lot of power with the physicians to help drive costs down. The other thing to really focus on is optimization of the operating rooms, in particular, efficiency and utilization.
Yeah.
So one of the things that we did over the past few years, there was a big push where Newton Wellesley was not going to achieve the volume of budgeted cases at the hospital. So the plan was to consider extending OR time. But the simpler solution was to take a look at the OR utilization and efficiency. And by rearranging our OR schedule, both at the main campus and at our outpatient surgery center, we took our efficiency or our utilization at the outpatient surgery center from about 17% to the mid 80s. Which is
Wow.
unbelievable. So we have increased profitability significantly by just using the rooms that we have. I mean, as one of my partners says all the time, the airlines don't make any money when the planes aren't in the air. So when you have
Yeah.
empty ORs, you're not being profitable.
Jason, that's exactly right. But one of the challenges for an AC to do that is, I can tell you, years ago I asked one of my centers for block utilization or the block schedule, and they literally gave me like a piece of paper out of a calendar book, and it was like writing on it, and then there was scribble, and then there was eraser marks. So what did you guys use software to do that, or did you just do it by hand or Excel? How did you guys really figure out how to optimize the blocks?
So at the beginning, it was awful, and
Yeah.
now we're doing it quarterly. So we did this about 3 or 4 years ago. We have one of our managers in the operating room who's in charge or of keeping track of all this data. The nice thing is that data is everywhere with everything that we do. And the utilization, the percentage utilization for these rooms exists by looking at the minutes per room versus the minutes per cases. So we were able to track that by physician. And then you break it down. We could actually break it down by day. So we could look at physician utilization, group utilization, and utilization by day. So we looked at the entire block schedule, and this was a ridiculous task. Without exaggeration, this took us tens of hours to do the first go around. The
Mhm.
nice thing is now that we're in year 3 of the iterations and we do this quarterly, it's much simpler to evaluate the data and make the changes. But we have our targets right now set at the main campus for 70% for the main campus and 85% for our OSC, and we're planning on increasing those numbers, which is a plus minus which we can go into for anybody who's business minded. It's very difficult to run things at a much higher utilization because there's lots of variability that creates risk with that. But the big push at the beginning was to take a look at everybody's rooms, and we've been right sizing every quarter. So what became a big sweep 3 or 4 years ago, we're reevaluating the data last week, and right now it looks like there's only 2 groups that need to change their rooms, which is pretty impressive. We typically do about 170 to 195 orthopedic cases a week between our 2 campuses. So the
That's
fact that we have gotten it to a point where our utilization at the main is well over 70 and over 85 at our OSC is fantastic.
pretty
So
fantastic. Did you get any pushback from surgeons like, "Hey, we're going to decrease your block time because you don't use it"? Well, no, 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 I use it. Did you get any of that?
We got a lot of that. There was a lot of
Hmm.
pushback regarding utilization. There's always a lot of pushback where people will
Hmm.
say that, you're penalizing me for being efficient. So, if
Yep.
I can get all of my cases done by 2 o'clock, why are you punishing me for that? And the answer is because nobody wants your time from 2 to 3:30.
Right.
So like, that's the issue. And everybody who operates knows that if you have a 2 o'clock start following somebody else who's been operating, you're not starting at 2 o'clock.
Nope.
And at a main hospital where there's staff around, that is usually okay if you bleed into the early evening. At some place like the outpatient surgery center, we have our patients go home within an hour of their surgery. So we certainly can't start creeping into the early evening because that means we have to keep an anesthesiologist there. We have to keep our PACU staff there. We have to keep our techs there. Everybody has to stay around if you're running late there, and you very quickly chew into your margin if you do that.
100%. That doctors don't realize that, oh, why are you not letting me have this case? Well, it's because you're going to go till 6, and now I got to pay an ologist and a PACU nurse to stay there. It's going to cost more money than that case is going to make.
Absolutely.
Jay, did you look at, I could hear Charlie DeCook's voice in the back of my head. Did you look at throughput as well as utilization? Because his mantra is 10 joints a day, 12 joints a day,
By noon.
by noon, 17 before I get there. The whole mantra of throughput versus utilization, the argument that a slow surgeon can utilize the room 100% of the time with one case. So how do you judge for that? Do you look at throughput as well?
Arjun, do you want to go first or do you want me to go?
I'll be honest, I wish we could optimize and I think there's a question in the chat that'll address it, but I wish
Yeah.
we could optimize our block time better. But as far as throughput, we have a lot of strategies that without looking at it, go towards it. For example, and I think Charlie does this too, we have all our blocks and our spinals done before the patient enters the room. So literally they enter the room, they get put on the table, prepped and draped, and it's go time. So there are definitely ways that we have tried to help that throughput without really looking at it specifically.
Yeah, great. Jay?
So throughput can also be directly related with the utilization.
Yeah.
So I just had a conversation yesterday with one of our spine surgeons that's feeling a little bit of pressure at the main campus because he takes a little bit longer to do some of his fusions. And as a result of that, he can't do multiple 2-level fusions in a day because he will go past his block time. So he is disadvantaged by that because if he's finishing at 1 o'clock, for instance, or 1:30, he can't add a second case in because that second case will take him past his block. So when you have surgeons that are a little bit slower, they can't fill their block, so they kind of self-select in that respect. So if you can't get a number of cases done because your cases take take too long, then you're automatically going to end up with lower utilization, which is going to right size your block by decreasing your availability for that. And what ends up happening is, particularly for our ambulatory surgery center, it self-selects. The people who are busy and are more efficient will end up there, and the people who are slow, they just kind of self-select themselves out because they can't fill their block.
Interesting. There
We've
was a
seen that happen with other specialties. Yeah.
Yeah, there's a question. Andy Nelson, you want to, under your video, you had a question about implant cost reimbursement. Andy, are you available?
Yes. There we go. So I'm a hand surgeon at a local urgent or a facility, do 90% of my cases there. And I'm trying to be conscious of implants, and we do not have a lot of data given to us. And I'm sure many of you guys have done the studies, just like with rotator cuff anchors and things like that. So although I'm personally trying to understand my costs, I don't generally know. My question to the group is, what things are generally covered by insurance and what is not?
Yeah. So
Because
that,
we're talking about joint implants, and if it's covered, kind of who cares? But bigger picture, and I don't know, big picture, are most things covered? Are half things covered? It really depends on your payer mix.
So it depends on a lot. It might even depend on what state you live in, Andy. So, for example, for us, we were looking at our cost of implants. Well, in New Jersey, the implants get reimbursed by the private payers. So, to be honest, the cost of the implant really doesn't matter because it just gets whatever the cost is, it gets passed through. But in Pennsylvania, it's part of the fee. So you really want to maximize your cost of the implant or minimize your cost of the implant, excuse me, to maximize your profit. So it really depends on what your state is and what payer it is. Now with Medicare, whether it's Pennsylvania, New Jersey, for us, the implant, the case is what it gets, and the implant is not covered. So it's really dependent on kind of where you are and what your contracts say, and that's the tough part. So having that transparency at your center is really important. The other thing, now we did joints, so I'm starting to look at plates, screws, all these other things. It becomes a lot harder when you're looking at multiple codes, multiple SKUs. With joints, it's all right, it's hip, knee. But it's a much more challenging, I think, and it's a much more difficult endeavor to really figure out cost of implants and getting prices down. So for our joint replacement, we used Avant-Garde, and they were very helpful in getting the numbers out there, benchmarking them against other hospitals, other facilities with similar more and less utilization. And I think we're going to have to work with them again, and it'll be a pleasure to do that for plates and screws, things like that. Question: do we just go all Stryker, for example, for plates and screws, or what do we do? Can we just get the price down? And it's a real challenge when you have as many different products, and hand and foot and ankle surgery, I think, are the toughest.
What is that organization you mentioned?
Avant-Garde, great consulting firm, a lot of great benchmarking data about implant companies or implant pricing and things like that. Supply pricing.
Sorry. So Derek Haas and Porter Jones are on the call with us right now. They're both with Avant-Garde. It's Derek's company. They have been fantastic. They have an amazing program where they basically will use all the data that exists in the systems that we use. And they have a very user-friendly platform that allows you to look at it specifically. So you can actually take a look at every one of your cases and say, okay, here's what it costs us for our gloves, for our sponges, for the medication we use in the room. We found 2 or 3 years ago, we were looking at costs across our shoulder scopes. And there was this one stupid cannula that showed up on every single card. And we're like, where is this coming from? And it turns out that at some point when somebody decided to make these disposable case cards for some of our shoulder scopes, they were putting this little blue cannula in. And nobody used it. It's too small to pass any instruments through except for a probe. Most of us didn't use it whatsoever, but it was an added cost for something like $49 or $59 for that one cannula that ended up in every single shoulder kit that we opened for our OSC. And when you think about a $59 implant across the thousands of scopes that you're doing in the course of a year and nobody uses, you're like, wow, we're throwing away thousands of dollars off of a stupid cannula that nobody paid attention to.
Yeah, and the thing of that is that could buy you more equipment. It could buy you another spider, right? it could get you things that the wish list that we all have our wish list as orthopedic surgeons. So that money can really be put to good use.
I have a follow-up question just with the culture of surgeons. I guess I'm trying to figure out how you guys have come to herd the cats. So just take rotator cuff, which I don't do, but I know it's topical and people use 3 anchors or 17 anchors and it's all over the place. What has been the effective communication to get multiple surgeons in a room and to not say, well, that's how I was trained, that's what I do, that's what works best for me, go away. Because I think that's largely what happens, some version of that conversation. So what is the strategy from the leadership to effective change? And I would think owners, if you're a surgeon owner, you do want to make more profit. So you should listen, but I'm just wary that that's effective. So I'd love to hear what strategies you guys have used.
Jason, you want to start with that one? I have to pull up some hate emails I got before I talk about it.
Sure. So I can give you two completely different environments. So in my previous life, one of the places that I worked, which did not have an outpatient surgery center, but we were looking at cost containment, we had to create a co-management contract. So it was a hospital system where we had private practice physicians and we had employed physicians, which is very much like where I am now. But in order to get everybody aligned, you really have two options. You have sticks and carrots, right? So the sticks are a little bit more complicated. The carrots, depending on where you are a little bit harder to use. So some of those carrots can be used with a co-management agreement where you say, you know something, if we can get everybody aligned with whatever company, whatever anchor, whatever implants, and everybody's in agreement, and we have this contract that says if we hit 70% utilization of this anchor, which is going to result in X dollar savings for the hospital, then everybody is going to share in a portion of the money that's saved. And that's determined beforehand. And you have your milestones or your guidelines set in place. So you say we hit 70%, we get X dollars, you hit 80%, you get Y dollars, you hit 100%, you get Z dollars. And co-management contracts work for a lot of places. Where I am currently does not do co-management contracts. And we have private practice physicians. We have physicians who have ownership in ASCs that are not affiliated with where I am. And we have employed physicians. And in those cases, you really need to get everybody on the same page. You really need to get people aligned. And the hard part is that there's no financial benefit for it. So how do you convince people to do that is you sit them down and you say, okay, so here's the implants that everybody's looking at. We can certainly do trials with them. You can try to see what it is. And then depending on where those trials go and what people like, and everybody has a vote in what implants you'd like to use, you sit down with the vendors and you say, you know something? Your product is this many dollars more than this company's product, but people really want to use yours. How can we get your price down so we can get them in here? And the answer is that if you have a product that's $100 more expensive, but we're going to use 0% of them, you get 0% of the revenue. If you can drive the price down a little bit, then they still do better because they are going to gain a larger market share of the product, and getting 70% of something that's slightly lower than what they wanted is still more than zero. So you can always work with the companies, particularly since there's a number of contracts that can be put in place where if you have a particular spend with these companies, you can get a reimbursement or you can get a cash back at the end of the year that go to the hospital. And as Arjun said, some of these things which you can speak to the physicians in the group is if you don't have a program where you can say we're going to give everybody a bonus based on this, you can say, you know something, we save X amount of money. We can consider buying 4 new arthroscopy towers for the OSC. We can fix up the break room so that everybody's happy. We can make sure that, we get all of this, whatever, new pump system from some company that everybody's looking at. So if you save some money and you have a little more money in your capital budget, then you can do more for the physicians, which will make everybody happier. So some of those carrots are really how you work them into the mix.
I have a slightly different experience because we're just a pure private practice and we're all in the same group. So for us, it should be pretty easy. You shouldn't really need sticks, and sticks don't work anyway, like Jason said. Should be carrots, because if we're all owners in this company that owns the ASC, we'll make more money if there's more profit. But, it comes back to, hey, what did I train with? But to be honest, I have some pretty prolific partners. Some of it comes back to what implant did I design? What implant do I have a royalty off of? And so there's conflicts there. But I thought the key for us, Andy, was one vision and backing of our leadership. So we had a vision where we wanted to bring costs down. We thought the prices were higher than they should be. And I really had the back. We presented the data to our team, some 25 or 30 joint surgeons, and everyone agreed. In theory, it sounded reasonable. And then we got problems. That's when I started getting hate phone calls and hate emails because what would happen was some of the vendors weren't really coming in. So we'd get information from our consultant Avant Garde that, well, two vendors agreed, but two vendors didn't. So if they don't agree by Friday, you won't be able to use like company X and company Y. And that's when the phone calls started happening. But fortunately for me, I had good backing of our leadership, my joint division chief, my chairman, and we stayed the course. And eventually, it did become a bit of a game of chicken, but we got to where we needed to get. And Jason's right; it does come to sitting down with these implant companies. A 10% cut off of I don't know, $1 million spend is a lot better than zero. And so that's where it kind of has to be negotiated. Everybody's sort of feeling this pain, and everybody's got to kind of work together. But ideally, Andy, physicians would be able to use whatever implant they want if we can get everybody to come and play on the same field.
Hey, Ira.
Yeah, Kevin.
Hi. I'd like to take a step back for the two gentlemen and first go back to ASCs or not ASCs. And I listened to this, and sorry, my dad was in business, and you're not really being fair. I want to talk about, why do you think a hospital should even have an ASC? They get more reimbursement. We need to fight for the self-standing building. There's no reason to work for a hospital. They are not interested. It's a vested interest. Who's speaking about a true ASC, a self-standing building that makes a profit, that works with the academy to say, you're not doing a good enough job to get me my reimbursement? Get out there. That's why I'm paying dues. I hear a mix of a hospital, 23 hours, maybe 4 hours, maybe 1 hour. Can I first define, what are we talking about today? What Charlie DeCook has a self-standing building, ownership of doctors, no hospital ownership. I'd like to hear from the two gentlemen. What are we talking about? What are the rules of engagement?
Yeah, that's a great question. Arjun, what's your arrangement? Because you're classically what I think Alex was also, or Fakao, you always call privatemics,
Right. Yeah, so we have different arrangements at every facility. And Kevin, that's a really good question. And so we have arrangements where a hospital might own 50%. We have arrangements where a hospital might own 25%. At Rothman, we decided, we knew when we built some of these centers, we were going to be pulling cases out of the hospital. So we wanted to partner with the hospital. But Kevin, I think you bring up a great point. I mean, if I could write it up all over again, right? These centers were built over the last, 20 years or so. If I could write it up all over again, I would do, give a management company maybe 5 to 10%, and I would let doctors own 95%. And it'd be a freestanding building outside of a hospital. And Kevin, you bring up another really good point. Like, what's the incentive for a hospital to own part of an ASC? Because they could really take a building and say it's just a hospital outpatient department, and just by that label get paid more. So it's a very valid question. And I would tell anybody, if they were developing a center now, more physician ownership, higher percentage of physician ownership, less percentage of non-revenue generators owning the facility would be the way to go.
Jay?
It's fascinating because I feel like you put me and Arjun on the spot, because we have completely different experiences, different viewpoints from where we are. So
some of Ira's genius, I'm sure.
Right. So it's that Bronx connection, right?
Yes.
So our outpatient surgery center is completely hospital owned. It's a 4 room outpatient surgery center that's owned by our hospital, and it's about a half-mile down the road from the main campus, which has all of the benefits of being a freestanding building, but it also means that if anything happens and patients need to get admitted, it's a half-mile down the street. The benefit so we have 0 physician ownership in ours. It's run by physicians who are employed currently. The previous model was it was primarily run by one of our private practice groups. that private practice group has now gone off and opened their own outpatient surgery center that they have ownership in. The advantage for the hospital is that number one, we have our outpatient surgery center is only orthopedics. So it is purely orthopedics run out of those 4 rooms. So we have economies of scope and scale there. We are incredibly efficient. We do a high volume of cases there. Our patient satisfaction is high. Our outcomes are excellent. We have moved total shoulders there in the past year based on the CMS guidelines, which is fantastic. And again, one of the carrots for that was a paper that we published with Porter and Derek on outcomes with outpatient total shoulders. So we have been able to take all of these orthopedic cases and put them in a place where our turnover time is shorter, the patient satisfaction is higher. The patients leave hand surgery, they typically leave within 30 minutes after their procedure. Shoulders and knees typically go about an hour after their procedure. And we have freed up space at our main campus for those ORs to take on the higher margin cases, the cases that have to stay in-house. So we have freed up the high demand rooms at the main campus by moving all of our orthopedic, particularly the hand and scope cases, to our outpatient surgery center. So a slightly different approach, slightly different model than what Arjun described, but for the hospital, it's been very beneficial.
So, Jay, I'm happy that you're helping a hospital succeed, which nauseates me. So, because there should be no justification for hospitals in the United States. But now, having said that, I tell you that kudos to you for best practice and treating always the patient, because it is always the patient at the end of the day. But I listened to the conversation, Ira, and they're worried about some piddly anchor or some other things. And if I listen to my Wall Street guys, they'd say, what a stupid doctor worrying about the anchor and the prosthesis. The answer is you don't deserve to be paid $900 to do a total knee. So I encourage all of you to get involved, that your reimbursement ups and knows what it is. And there are possibilities to demand it and say no. And I encourage you to have reasonableness, because you're not being paid the right amount. And so you're searching to the bottom. And I'm sorry for that. Welcome to New York City, where we don't take insurance. We take out a network and demand it. So I say to you,
but I'm gonna take you on.
you can do Medicaid, and you deserve to do for those that don't make money to do it free, Ira.
Yeah.
I've figured it out. You do free for people that can't afford it, and you snooker the wealthy, and you understand what is in the middle. And I will make sure it happens to all of you. But I love that you're doing great care. But I would say try to extract yourself from the hospital, because ultimately, if you're owned, it's just like a residency. And I'm done with my residency. I love you guys.
Well, I have no comment on that personally, because I'm the moderator. So I will do this as a offsite. It's very, one thing for sure. There are many models out there, and there are many motivations. I mean, I gave a lecture one time on various things that motivate orthopedic surgeons, and it's a wide range of things. It's going home, making money, doing the right thing, covering your ass, marking your practice, and power, glory, and ego. And those are the 6 things that motivate orthopedic surgeons. And it depends on what floats your boat, to be what kind of practice you're in. So I'm just going to switch over. Marty, you have a question, Marty Nichols?
Well, I just threw out there the true solution to that, shouldn't it be that, look, it's the same doctor and the same implant going into these facilities. Why do we tolerate a 3 to a 10x discrepancy in what a hospital gets paid versus what a physician surgery center gets paid? And we shouldn't be necessarily racing to the bottom, but we should find the middle ground between those two prices, and it should be any willing provider. And at the end of the day, I believe the reality is there'll always be a need and a place for a hospital-employed physician, and that's good. We should encourage and have that. What we shouldn't have is a situation or a payment system that forces someone out of private practice to become an employee of a hospital. They should get to choose. If you want to be private practice, you should be able to afford and get paid to do that same procedure in private practice as somebody that gets paid as an employee.
Yeah. let's I'm just going to bring us back to ASCs for a second. Um, and talk about, because ASCs, of course, is one of the passive revenue generators for a practice. Um, Arjun, in your experience for your group, um, not giving specific numbers, do the surgeons feel very if they were asked, I feel very happy with the revenue I'm collecting from my surgery centers. 1 to 5, 5 being I agree with that statement, 1 being I don't agree with that statement.
I'm going to quote my chairman, Dr. Vaccaro, as something that doesn't exist. Unicorns and orthopedic surgeons that they think they make enough money. So, no, I would say we'd get a mixed bag on that. I would say most of our partners would say, "Oh, we should be making more." I have a friend in Oklahoma that makes 3 times this. So, our shareholders do take home money from the ASC and specialty hospital ownership they participate in. Um, whether or not they're satisfied with it, whether or not it's appropriate, that's a different story. But I think the key for physicians is, as you mentioned it, ASCs are really a good ancillary source of income, especially in light of all the reimbursement decreases over the last decade or so. The key to that, though, is physician ownership and physician engagement in the ASC. So physicians need more percentage ownership, number one, and you want to keep that high, at least 48% physician owned, if not more. And engagement. The physicians can truly drive the cost, the everything, the supply cost, the implant cost, utilization. So physician engagement and leadership are key to that. But yeah, it's a mixed bag if people would say they're happy.
Yeah. How does data, how does access to data, and Jay, I'd like you to comment on this. Yeah, access to data that you've gotten from, relationships, whether it's relationships with Avant-Garde or with collecting your own data or using spreadsheet, we live and die at our hospital by the data we get, and make decisions based on data. But a lot of people talk about not having access to data. So talk about, do you have access to data, enough data at your hospital where you are as an employed physician, and how do you get that data and how do you use it?
So, in respect to the ASCs or in respect to life at the hospital, because I
Life
can
at
give
the
you both
hospital in
answers.
general, and then the ASCs. Yeah.
So, I love data. I mean, it's really fantastic, and we live in a data-driven age, and it's all big data. And every single one of us who is using some sort of an electronic medical record, or if you have Epic in your hospital system or any of these EMRs, the data exists. It's a question of whether or not you have access to it or have any interest in it. So I was not aware of the level of data that exists, and how some groups and some not only inside but outside of the hospital have access to the data that is being produced by every single one of our patient experiences.
Right.
So you have a group like Avant-Garde, which has really done an amazing job of really stratifying the data. Like we can hone in on any surgery that we can pick total joints at Newton Wellesley or in Mass General as a whole, and we can look at implant cost, surgeon time, how much it costs for their gloves, what people are using for implants, what people are using for antibiotics, what people are using for cement. Like it is unbelievable the level of information that you can get. And when you look at a big system, having this access to the data, you can find very small things that happen so many times over that by fixing one tiny thing, the magnitude of the change is enormous.
Yeah.
Now that's for cost. For data in my office, we have a walk-in clinic that we launched, and I'm very interested in all of these things. And I have a very good relationship with one of our local colleges, which has a business analytics program. So I'm actually working with them right now to be a mentor for their Masters of Business Analytics. And we are working on having a group of students come through every 14 weeks. And we're going to give them access to de-identified data to take a look at programs in our system. So a few of the programs that we're looking at right now is X-ray efficiency, for instance. So when you're looking, you had mentioned throughput earlier for the ambulatory surgery centers, but when you look at throughput through X-ray, for instance, as your patient volume goes up, are you efficiently using your X-ray machines, or can you get more people in a more expeditious fashion so you can get them taken care of? When we run our walk-in clinic, I need to look at staffing models. So I can look at the data because we can track all of this. I know that on average, my patients who show up in our walk-in clinic, door to door is 67 minutes. The question is what's my ebb and flow from 8 in the morning to 8 p.m.? So how can I staff up my PA team to make sure the patients are being taken care of and we don't have huge waits? So now we're looking at the data because we have a ridiculous number of 1,200 to 1,300 patient encounters per month through our walk-in clinic. So you look at that data over the course of the year, and you get the ebb and flow, not only week by week, but day by day and hour by hour. So you can start to run it and say, you know something, we're not busy between 8 and 9 in the morning, so we only need one person. And at 9, we need to be double staffed. And by 5 o'clock, we need to have 1 or 2 people on. But by 7 p.m., we need to have 3 people available. And you can do all of this based on the data that we can collect and look at. And this data exists. You just need to look for it.
Arjun, do your surgeons get any dashboards on a regular basis related to actionable data?
We do on a quarterly basis. We meet as a joint team, and each subspecialty meets, and we get data. We get data on readmissions, complications, etc. We have a team of analysts at Rothman that can run reports on a number of things. So we have opportunity to get data. I think the tough part with data, and we make many decisions based on data. When we're looking at staffing, when we're looking at offices to open, this is getting a little away from ASCs. But the tough part is like Jason said, you have a program like Epic, and there's just so much data. And so, do I have the ability or time to even sift through a massive spreadsheet full of all kinds of data? So really helpful to have somebody. We have a group of analysts. We use Avant-Garde at some of our surgery centers to kind of sift through the data, because data is great. But I think you have to make it meaningful so people can understand it, and that can make it actionable.
Excellent. I'm going to show something on my screen here. Share. This was an article written, oh my God, in JOEI. Go figure. In my experience, 7 strategies for enhancing ASC profitability. I encourage people to view it and join 1,553 other people who read the article. Derek Haas, Porter Jones. It's written really beautifully well and covers a lot of the things we've covered today. Okay. Improving OR utilization, we talked about. Timely revenue collection, case mix. We'll talk about that in a few minutes. Leveraging technology. So there's a lot of things. I wonder if each of you could share in your ASC something you did that didn't work out, and sort of a lesson you learned from that. Do you have one of those?
I have a quick one if you want me to go, Jason.
I'm happy you can go first. I'm happy to go first. Your call, Arjun.
Go ahead.
Fall on my sword if you like.
Go ahead.
So we spoke earlier about the efficiencies and the economies of scope and scale. So one of the wonderful things about our outpatient surgery center is it's all orthopedic. So we have done a very good job of making sure it has stayed orthopedic. However, there were a number of people that said, you know something, if we're talking about moving cases out of the main hospital, why don't we consider doing our outpatient total knees at the surgery center? Because we do them as outpatient at the main campus, why not move them to the OSC? Some of us disagreed with that plan because it did not fit in the model of what we were doing at the outpatient surgery center, as far as the need for physical therapy, the need for the perioperative care, the equipment in the room, all of the things that you start to look at when you're trying to decide how to do a total knee. So this was driven by a few people, and they were very adamant that this was going to be successful, and it was completely successful. The few people that had their total knee replacement done at our outpatient surgery center had a great outcome. There were only a few of them. That program fell to the wayside. The patients needed more care in the PACU. They did not fit in the let's get them out of here in an hour model. They didn't fit with the postoperative care that the PACU team was used to delivering. And we spent a lot of time trying to get this program off of the ground, and it didn't work. Now, the corollary to that is that that was a lovely platform for us to say, you know something, total shoulders fits in the scope of what we do here because it's no different for the postoperative care than what we do for rotator cuffs. And we now have a successful outpatient total shoulder program that's developed out of our outpatient surgery center on the back of or heels of the failed total knee program.
I'm amazed. I'll be honest with you, I'm going to take a moderator's thing. You know, why didn't those guys go down to Charlie DeCook and figure out how he does it? Because he does it.
I don't think
everybody's doing it, Ira.
What's that?
I mean, everybody's doing it, but maybe I'll try to answer your question, Jason, and or Ira's question for Jason. And Jason, you'll tell me if I'm wrong. I would say there just was no incentive for the physicians to do that at the end of the day. They can fight the fight with PACU, they can work with anesthesia, but what was the incentive?
When you have a program that's successful at the main campus, where when people are running double rooms, they can do 6 to 8 total joints and get everybody home. You're right.
Yeah.
So there wasn't a physician incentive. This was an exercise in can we do it? And you're right. The buy-in wasn't there. The alignment wasn't there. The motivation wasn't there. And I think at the beginning of this conversation, we were talking about who wants to operate at an OSC and the efficiencies and the physician ownership. I have no ownership in it, but why do I like to operate there? I can get my cases done there. I can always get my cases added on there. There is always availability for me to get my things done. My patients love going there. The staff is amazing. The culture is fantastic. There is no downside for me to do cases there. When you have somebody who does a few total joints occasionally going there, it doesn't fit with our model, which is why I mentioned economies of scope. It didn't fit in the scope. So when you think of what fits in the scope, where are things going to be beneficial? Bringing a total knee over there is just as off-putting for everybody as bringing a hernia repair. It just didn't fit.
It's interesting, and you know that's kind of the opposite of what we see across the country. And so, but it's all about incentive. So, for example, the first time I did a total knee at my surgery center, which I owned in 2015, 3 years into practice, literally went there, did lunch and learns, talked to the PACU nurses, had anesthesia. Luckily the anesthesia group was from the hospital, so the anesthesiologists were okay with things. Did one knee replacement. Our office was next door, so stayed there for hours afterwards, did multiple checks with the nurses because they weren't used to it. And I had another partner that basically treated it the same way. And once we did, 6, 8, 10, it was like, okay, now you can leave as the patient's leaving the room and we'll call you if there's a problem. But, I took the time and the effort to do that. And I had the incentive to do that. I was a new partner at the center and I wanted to bring, my piece to the center. And now, 9 years later, we have a Mako robot at our center. We probably do about, I think it's over 200 total joints at the center. And we haven't even started really doing hips because we're kind of full with knees. We're actually expanding the center now. So it's going to go from 3 to 5 rooms. Now we'll probably start adding hips in more cases. Now it'll get to a point where we'll have 2 rooms and 2 teams, et cetera. Right now we're still in 1 room. So a lot of buy-in, but again, the only reason my partner and I, took the effort to do this was because we were owners.
Interesting. I'm going to give us as most JOEI nights, this goes pretty quickly, although an hour is an hour. Looking ahead, what do you guys think are the most significant opportunities for ASCs to increase profitability and use data analytics? We haven't talked as much about some tools out there that are looking at ways to give you information about where you are in the operating room at any given time. Companies like Ospitec and others who are really looking and I am not a consultant to them, so I just know that they do this stuff. Avant-Garde has huge amounts of data they can give you. So where are the opportunities for profitability and growth? Because ASCs are, as we like to say, here to stay, of course, and more and more people are demanding it. I had both my knees replaced, one in 2016, 2017, and I was out of the ASC in 2 hours. And that was back then. So where are some of the more significant opportunities for ASC profitability?
Yeah, I think number one, you hit the nail on the head, and Jason's talked about it as well. We're going to need to keep using tools like data and analytics to get smarter, to get better. Like Ospitec, a company like that, they can really tell us what our timing is with everything. Where can we get utilization better? So those are opportunities. But I think the biggest opportunity moving forward is really managing the case mix. If we really look at the contribution margin, and we did this internally of, let's say, a spine or a joint case versus a hand or a pain case, it's pretty clear that, the bigger cases reimburse more and can contribute more to the bottom line. So if we're truly just looking at profitability, we may see a change where, there are ASCs that instead of just being orthopedic only, might be like joint only, like Charlie DeCook, or might be spine only. And that's one way to really maximize profitability. And I think data is going to help with all of that. And that, that world is so non-transparent, right? Like, how much did I get paid for that case? Or how much did I get paid to see that patient in the office? I mean, usually the answer is, I don't know. There's 10, how many different companies, how many different contracts. So kind of delving through all that, as doctors, we need help there because we don't have the time to do that. And that kind of dovetails into rev cycle. That's something we've talked about a lot at our practice. We had some struggles financially a couple of years ago. And one of the things we noticed there was our rev cycle was way off. It was taking way too long to get our money. And so we really shored that up. And now we're in a place at Rothman where, forget the ASC stuff, just even as a practice, doing much better. But you have to stay on it. Like, you can't just say, oh, we fixed the rev cycle and it's good. You have to stay on it. You have to have dashboards, analytics to kind of keep on it to make sure that it's not slipping, because the insurance companies, everybody's going to look for a way to not pay you or delay paying you, and you have to make sure you stay on it. So I think that's a real big challenge. And, when you're looking for leadership at a center, a specialty hospital, whatever it is, having someone with an eye on that, a knack for that, is going to be really important.
That's critical. I really tend to agree with you that we leave a lot of money on the table, and you wouldn't do that in Vegas. Yeah. Jay, some comments on that, and you may be bringing us home tonight as a final comments. Oh, you're muted. You're muted, Jay.
Total rookie mistake. So I apologize for that. I didn't want to interrupt Arjun. He was saying so many brilliant things. I didn't want to interrupt. But I completely agree with what he said. And I think that there are a number of things we have to look at. So part one, Arjun, you brought up the contribution margin and the reimbursement that we get for the hand cases versus sports cases versus joints versus spine. And from where I sit, having, working as a hospital employee, that's one of the reasons why we move the sports and hand cases over to the OSC, because we can do a much higher volume of cases because the OSC is very good at turnover. Everybody who's operated at a main hospital, even though they try to get their turnovers down, it is a big machine and it's harder to move the rooms at the main campus. So our hand surgeons can get a lot of cases done in the same amount of time that they would get few cases done at the main campus. The same thing for doing any of our sports cases. We are much more efficient, which a much smaller turnover time at our OSC, which frees up the larger cases, the total joints, the spines, which are higher margin cases, to use the rooms and the resources at the main campus. When we talk about the data and where can we go with this, we've hit on the point that we don't know what our costs are. So having companies like Avant-Garde and having people like Derek and Porter around to pull up this data for us and show us, where we're spending money unnecessarily, it's pretty amazing because you think about all of these things that we waste money on. A shaver that gets opened on every single case that nobody uses, or they open the wrong shaver, but nobody realizes how much it costs and you open a second one. You do that over and over and over again, and you're throwing money away, right? I mean, most people here wouldn't open a bottle of white wine with dinner and then say, no, I really want a bottle of red, and you pour the white down the garbage, right? You don't pour it into the sink and just move on to the red. You're going to have the white or cap it. In the OSC, you open a shaver, someone says it's the wrong one, and before you have a moment to respond, they open a second one, and you just poured that bottle of white down the sink. So
That is a fantastic analogy.
thank you.
Absolutely.
So we throw money away left and right. We throw money away on our trays in the operating room. So there's opportunity in our OSCs and our even our main campuses. When you look at how many things we have in our trays that go unused, same argument going with your kitchen. You don't take all 10 sets of plates out of your cabinet and set the dinner table every night for two people, because then you have to put them all away or put them in the dishwasher and run the water and use the soap and put them away when you're only using two plates. And when you have instrument trays that are set up wrong, you're using all of these instruments and you're doing the same thing. You've got the human cost of the labor cost of putting everything away. You've got to wash everything, sterilize it, put it back in a tray, count it, and get it ready to go. So we have so many opportunities to fix things. And then when you look at the data, which was the big question, even things at an OSC where you look at turnover time, it's not a matter of can you shave off 2 minutes here or there. You want to shave off enough time and become more efficient so you get that extra incremental case in. At the beginning of this, we talked about that you don't make money when the planes aren't in the air. If we have an OR that's not efficient and you can only get 4 cases done, but you cut down that turnover time from 33 minutes to 15 minutes, and suddenly you just saved 50 minutes in the course of a day. Suddenly you've got an incremental knee scope at the end of the day, or you've got an incremental carpal tunnel at the end of the day. And that is all incremental revenue that wasn't being counted. And you do that across 4 rooms, 5 days a week, and suddenly you just increased what you're doing by 20 cases a week. And that's all extra revenue that you're bringing in if you're a physician-owned group or you're bringing into the hospital that you work for.
It's great stuff. Arjun, you have any final comments? Or are you good?
No, great conversation. It was really interesting, Jason, to kind of hear your perspective as, a non-owner of an ASC, but someone who's a real champion. And it's just a really interesting perspective. So, Ira, just thank you so much for having us. It was a really great conversation.
Yeah, I want to thank everyone for being here. All the faculty, of course, Arjun and Jay, and the many faces and names I see commonly on the JOEI nights. This was a great one. I want to thank the Avant-Garde team for helping support this, and for everyone for spending an hour with us on a Wednesday night. All right. So I'm going to say good night to everyone, and we'll see you at the next meeting.